Hello, and welcome to Noon Conference hosted by Medality. Noon Conference connects the global radiology community through free, live educational webinars that are accessible for all, and is an opportunity to learn alongside top radiologists from around the world. You can access a recording of today's conference and previous Noon conferences by creating a free account. Today's Noon conference is provided by the France Foundation, and we are honored to welcome Dr. Mary Salvatore for a lecture entitled The Critical Role of the Radiologist in the Diagnosis and Surveillance of Patients with Bronchiectasis. Dr. Salvatore is the chair of radiology at Jacobi Medical Center in New York City. She specializes in thoracic radiology with a specific focus in interstitial lung diseases and patterns of fibrosis on CT. She's actively involved in research, retrospectively reviewing well-established CTs of usual interstitial pneumonia and looking at earlier exams to determine earliest CT manifestations of disease. Additionally, she has written a text on CT interpretation for non-radiologists. Her ultimate goal is to affect as many people in a positive way as possible through education and a positive attitude. At the end of her lecture, please join her in a Q&A session where she will address questions you may have on today's topic. Please remember to use that Q&A feature to submit your questions so we can get to as many as we can before our time is up. With that, we are ready to begin today's lecture. Dr. Salvatore, please take it from here.
Thank you so much for that wonderful introduction. I'm so happy to be here today to speak about the critical role of the radiologist in diagnosing bronchiectasis. Thanks to the France Foundation for providing this opportunity. Next slide, please. Our steering committee members are listed on this page. Next. Our disclosures. Our learning objectives for this conference are going to be to confirm the presence of bronchiectasis via high-resolution CT scan, to determine how radiology imaging can help determine the etiology and treatment for the bronchiectasis, and to summarize the needs for subsequent radiologic surveillance of patients who are diagnosed with bronchiectasis. In the beginning, we'll speak about an introduction to bronchiectasis, how to make a bronchiectasis diagnosis, the CT procedure to get the best diagnosis of bronchiectasis, how important imaging is for bronchiectasis etiology and treatment, and a case presentation. Please use your phone to scan the QR code once and keep it open to respond to the questions throughout the presentations. Introduction to bronchiectasis. What is bronchiectasis? As a radiologist, I call bronchiectasis maybe on at least 1/10 of the patients I see each day. So it's a very common problem. And I use the term bronchiectasis when I see that the bronchus is bigger than its accompanying artery, like in this picture. We see the arteries maybe about 5 millimeters and the bronchus is about 10 millimeters. So whenever the bronchus is bigger than its accompanying artery, we can use the term bronchiectasis, and it's permanent dilatation. So it's irreversible dilatation of the bronchus bigger than its accompanying artery. Bronchiectasis is a big problem, and it's increasing. Compared to 2013, there were about 200 out of 100,000 people with bronchiectasis, and now in 2025, that number has more than doubled to 478 per 100,000 people with bronchiectasis. So a big problem and a great opportunity for radiologists to be able to diagnose the disease early. What is the cause for bronchiectasis? Bronchiectasis is frequently caused by a bacterial infection and colonization. When you have this infection, the body wants to rid the body of that infection, and neutrophils come to the rescue, bring inflammation and their corresponding elastases. These elastases cause airway destruction when they are excessive. And you can imagine as the airway gets destroyed and larger in size, that you're going to accumulate more mucus, which is going to bring more neutrophils, and it has a continuous vicious cycle that propagates bronchiectasis. Next slide. Not all of bronchiectasis have neutrophils. 20% of them are associated with eosinophils. The neutrophils, though, are very important because they bring along their elastases, which cause destruction. These elastases also create neutrophil extracellular traps where the infection is caught and eradicated from the body. So as equally problematic as they are helpful, the neutrophils, in fighting infection. Next slide. How do we define a pulmonary exacerbation? In general, it's a worsening of symptoms that we attribute to the underlying condition of bronchiectasis. But if you're doing a research protocol, you're going to look for a certain definition for what is an exacerbation. And typically they use that it's a deterioration in at least 3 of these symptoms that are listed below for longer than 48 hours. And they include worsening cough, increased sputum volume or thickening, more purulent sputum, breathlessness, inability to exercise, fatigue, malaise, or hemoptysis. And then the clinician determines if a change in the treatment for their bronchiectasis is necessary. This is when we consider it an exacerbation of the bronchiectasis. Next slide. This is our first question. What do you know? A patient presents with a chronic productive cough for the past 3 years. Which of the following would provide a diagnosis of bronchiectasis? Is it airway to artery diameter ratio above a lower threshold of 2, lack of airway tapering, non-productive cough, or presence of an underlying condition such as asthma? In order to make a diagnosis of clinically significant bronchiectasis, you need radiology and clinical correlation. Clinically, the patient must have 2 or more of the following symptoms: a cough most days of the week, sputum production most days of the week, or a history of exacerbations of their bronchiectasis. Radiographic confirmation is obtained by the presence of greater than or equal to 1 of the following: airway to artery diameter greater than 1, but we feel more confident when it's closer to 1.5. And the pulmonologists tend to use 1.5, whereas the radiologists say a pulmonary, bronchus to artery ratio greater than 1. A lack of tapering, right? As we go from central to peripheral, the bronchi tend to get smaller. If they don't get smaller, then that's another sign of bronchiectasis. And when we see airways that are not traditionally seen in the periphery of the lung, that might be a sign of bronchiectasis as well. Next slide. A chest X-ray is not sufficient for the diagnosis of bronchiectasis. We may get a hint that there are cystic changes or tram track lines, but look at how much better we can see bronchiectasis on the last image with the airway thickening and the dilated airway bigger than its accompanying artery. So CT scan is the mainstay for imaging of bronchiectasis, and chest X-ray is not sufficient. Next slide. When do we suspect bronchiectasis? It's hard clinically because bronchiectasis can present in a way similar to COPD and asthma. We become more suspicious with certain congenital diseases or autoimmune diseases, immunodeficiency, and even inflammatory bowel disease can be associated with bronchiectasis. So we might have a high level of suspicion, but it can be challenging clinically because there's so much overlap. Next slide, please. What did you learn? A patient presents with chronic productive cough for the past 3 years. Which of the following would provide a diagnosis of bronchiectasis? The answer is lack of airway tapering, because the airway to artery diameter ratio above a threshold it should be 1, not of 2. And a non-productive cough is not specific, or the presence of an underlying condition. So the lack of airway tapering is the correct answer. Next slide, please. So we do CT scans so frequently now, and how should we do them in order to get the best diagnosis for bronchiectasis? It's important to use, to not have motion artifact. That's probably the most important part of having a good quality chest CT scan, is that the patient is not breathing during the exam. And so a non-contrast chest CT scan is very important. When we give contrast, the patient feels warm all over, so they become more anxious and they start breathing more quickly. So non-contrast chest CT scan, we want to use thin slices. When I first started doing my residency, we had 10 mm slice thickness, and that would not do well to diagnose bronchiectasis. We need to have a slice thickness less than 1.5 millimeters, and in my institution, we use 1.25 millimeters. We want to ask the patient to take a full breath in and hold it. That's very hard for some of our shorter breath patients, so it might be wise for the technologist to practice with the patient correct breathing technique. And we're working on improving that at our institution to help the patients to cooperate so that we can get the best exams. Expiratory images are important to see air trapping. We don't do them on all of the CT scans that the patient comes back for, but on the first CT scan, when we're trying to make the diagnosis of air trapping, we'll do an expiratory CT scan. And again, that quality is important as well. Otherwise, it becomes a double dose of radiation without much benefit. So we can practice that with our patients to blow out all their air and hold it for an expiratory CT scan. Next slide. I love the anatomy of the lungs, and I'd like to just talk about the central airways, and so we could describe what airways are involved with the bronchiectasis. The right upper lobe bronchus has three parts. It has an anterior, a posterior, and an apical. When I look at the right upper lobe bronchus, I can't help but see a goldfish cracker. I don't know if you've ever had goldfish crackers. If you have, you'll never look at a goldfish cracker the same after seeing that it looks like a right upper lobe bronchus. You'll never look at the right upper lobe bronchus the same now you know that it looks like a goldfish cracker. The right middle lobe is easy to recognize because the M and the L in middle lobe are the same as the subsegments, so medial and lateral. The right lower lobe looks like a compass to me. Instead of north, south, east, and west, it's anterior, posterior, medial, lateral, and superior. So the right lung has 10 segments. The left lung has to be smaller because we have the heart occupying part of the left lung, so things get combined. Instead of having an anterior and a posterior in the right upper lobe, we have anterior, posterior combined. I'm sorry, apical and posterior combined, and then an anterior. Instead of a medial and lateral, we have a superior and an inferior. In the left lower lobe, anterior and medial are combined, so we have 4 segments. So ultimately, on the left side, we have 8 segments, and on the right side, we have 10 segments. Next slide. How does imaging help in determining the etiology of the bronchiectasis? So when we see on CAT scan, how specific can we be about what is causing the bronchiectasis? Next slide, please. This is our question number 2. Please take a moment. A 52-year-old woman has worsening indigestion over the last 6 to 9 months, as well as a persistent and productive cough. Chest CT reveals diffuse basilar bronchiectasis. Which of the following is most likely to be an underlying cause of this patient's bronchiectasis? Is it allergic bronchopulmonary aspergillosis, bacterial pulmonary infection, chronic aspiration, or undiagnosed cystic fibrosis? Take a moment to answer that. We can go to the next slide. CT features can help us to differentiate different types of bronchiectasis. So when we think about allergic bronchopulmonary aspergillosis, it's a very dilated bronchus, more so than with chronic aspiration. And it's more the central airways that are dilated, and in a characteristic finger in a glove appearance, which we'll see on subsequent slides. In contrast, chronic aspiration is maybe milder dilatation of the bronchus, usually in the basilar regions of the lungs, because when you aspirate, that's where the aspirated materials go. And you might see tree and bud opacities, which are more characteristic of chronic aspiration than ABPA. Next slide. We talk about the degree of bronchiectasis by using three terms radiographically. There is cylindrical bronchiectasis when the bronchus is bigger than its accompanying artery, but there's relatively smooth dilatation. In contrast, varicose bronchiectasis has an undulating contour, so it's still a bronchus that's bigger than its accompanying artery, but instead of being smooth, it's undulating and weaving like a string of pearls. And then cystic bronchiectasis would be considered the worst kind of bronchiectasis. These bronchi are very dilated. And if you were to do a VQ scan, you would see that there was no perfusion to the area where there was cystic bronchiectasis. So it's not taking part in oxygen exchange. Next slide, please. So I love this article from Dr. Lynn Reed. It was written in 1950. Can you imagine in 1950, Dr. Reed was doing dissections, and she saw that in normal individuals that their bronchi branched 16 times from the time of the trachea to the periphery of the lung. We now know that there are 26 branches, or at least currently we believe that there are 26 branches. So from the trachea, there are 8 conducting airways that are segmental. Then there are 8 subsegmental conducting airways. And then there are 8 respiratory segmental airways. And then there are sacs and ducts. So a total of 26. At her time in the 1950s, she was able to see the conducting airways, the 8 conducting segmental airways and the 8 conducting subsegmental airways for a total of 16. And she said that cylindrical bronchiectasis maintains those 16 conducting airways. But what happens when you have varicose bronchiectasis, we said was more undulating and more dilated, you have some truncation or pruning of the bronchi. So instead of having 16 branches, now you have 8 branches. And with saccular or cystic bronchiectasis, the worst type of bronchiectasis, you have further pruning to only 4 branches. And she identified that as the change that occurs with bronchiectasis. And we still use her grading system today with cylindrical, varicose, and saccular. Next slide. So we can say what type of bronchiectasis they have. We can say its location, but how do we get to what disease is causing the bronchiectasis? Well, we have focal bronchiectasis gives us a narrow differential diagnosis. Most of the bronchiectasis are more diffuse. And then we have to look at if they're central or peripheral, and that helps narrow down our differential diagnosis. Let's look at a few cases. Next slide. In this example, we have a focal left lower lobe bronchiectasis. We see that the airways are bigger than their accompanying artery. The differential for this kind of pattern includes the patient may have had an infection in the past and left the bronchus dilated because of the elastases, and that's going to cause a focal bronchiectasis. But that's not the only reason that you can get focal bronchiectasis. In children, oftentimes it is because of aspiration of a foreign body, or in adults, maybe a tooth. Bronchial stricture can cause focal bronchiectasis. An endobronchial mass, like a carcinoid tumor, can cause focal bronchiectasis distal to the obstructing mass. Also, something that we don't see too commonly now is broncholithiasis. So the calcified lymph node in the mediastinum can erode the mediastinum and go into the bronchus and cause broncholithiasis. And then congenital bronchial atresia with dilatation of the bronchus due to an obstruction with mucoid impaction. And the hallmark of that is surrounding air trapping. Next slide. More commonly, we see diffuse bronchiectasis. And then we can think about narrowing our differential. We said that there's 26 branches of the airways from central to peripheral. Well, what if a bronchiectasis affects the more proximal airways? It's going to narrow down our differential. Meunier-Kuhn's disease is tracheobronchomegaly. So when we see a dilated trachea and central bronchi, We can think about Meunier-Kuhn's disease, very rare. The trachea has to be bigger than 3 centimeters in size. I think I've seen this twice in my 25 years of doing chest radiology. In contrast, allergic bronchopulmonary aspergillosis is much more common, and we see it frequently in patients that have asthma and cystic fibrosis. These are dilated airways that are from the first to the fourth branch. So we said that there is 26 branches. When the first to the fourth branch are dilated, we think about ABPA. And since these are central bronchi, they are bigger bronchi. There is mucoid impaction in these dilated bronchi, giving the classic hand or finger and glove appearance, where the glove is the dilated bronchus and the finger is the mucus that's impacted inside of it. If we don't remove that mucus, it becomes desiccated and calcified over time. Another disease, excuse me, that affects the central airways is Williams-Campbell. I'm just going to take a drink for a second. I'm sorry. Williams-Campbell, unlike ABPA, which affects the first to the fourth, affects the fifth to the eighth branch of the airway. And there's a lack of cartilage. So when you see the central airway being normal in size and the middle airway being larger and the distal airway being normal in size, think about Williams-Campbell. When the patient breathes out with Williams-Campbell, because of the lack of cartilage, the airways collapse, and it gives a characteristic appearance of Williams-Campbell. The next slide, please. Here's an example of Meunier-Kuhn's. You get tracheobronchomegaly, but you also get bronchial diverticulum. Next slide, please. We talked about bronchopulmonary aspergillosis, allergic bronchopulmonary aspergillosis. There are 4 types of aspergillosis infection. The mildest is an aspergilloma occurring in a pre-existing cavity. This ABPA is associated with asthma. And then we have invasive and semi-invasive aspergillosis in immunocompromised patients. Next slide. Williams-Campbell, if you suspect it, you do an expiratory CT scan and show that the bronchiectasis collapses. Next slide. Now we're talking about more diffuse bronchiectasis, not just in the central airways, but more diffuse. And we think about upper lobe bronchiectasis. When I see bronchiectasis in the upper lobes, especially if it's in the back of the upper lobes, I think about sarcoidosis. If it's in the upper lobes and there's associated with a lot of mucoid impaction in a younger person, I think about cystic fibrosis, which was first described by Dorothy Anderson when she noticed that children with salty skin were dying from respiratory infections. And upper lobe bronchiectasis, just like sarcoid in the back, tuberculosis is a bronchiectasis that affects the upper lobes in the back. Next slide, please. Thank you. What about if the bronchiectasis is in the lower lobes and not in the lower lobes? We have an excellent example of chronic aspiration. We can see even that there's debris within the right lower lobe bronchus. Often they get tree and bud nodularity. Lady Windermere syndrome, the next case is NTM, non-tuberculous mycobacteria infection. They get the classic dilated bronchi in the right middle lobe and the lingula. The bronchus is bigger than its accompanying artery. This is usually in older women. We see this maybe 1/3 of the women that we see have this Lady Windermere type syndrome. They're usually thinner with dilated bronchi in the right middle lobe and the lingula, but it can be in the lower lobes or it could be diffusely. And then finally, if I see a young patient, oftentimes a male patient in their 20s who has a history of recurrent infection, and I see a lower lung bronchiectasis, bronchial wall thickening, I think about desmodal cilia syndrome. If their heart is on the right side instead of the left, we call it Cartageners. If they have yellow nails and desmodal cilia, we call it yellow nail syndrome. If they have azoospermia, we call it Young syndrome. So desmodal cilia is the broad category, but there are subcategories as well. Next slide, please. And so here we have another example of Lady Windermere syndrome with the dilated bronchi. We can see them really well here. The artery is smaller than the accompanying bronchus with the signet ring sign in the right middle lobe, especially very characteristic of Lady Windermere. Next slide. Here we see a wonderful example of lower lobe bronchiectasis in a patient with dismodal cilia syndrome, a young patient. Next slide. An important thing is air trapping. It can be very confusing and challenging to make the right diagnosis. When we look at the first CT scan, this is an inspiratory CT scan, we see heterogeneity. And that heterogeneity we call mosaic attenuation on an inspiratory CT scan. We see areas that are darker and areas that are whiter. And the thing that we have to do on this CT scan is then to look at the darker areas like we see in the right lower lobe and ask ourselves, are the blood vessels smaller in the darker area? If the blood vessels are smaller in the darker area, it means that the darker area is the sick area. If the blood vessels are the same size in the darker area compared to the whiter area, it means that the whiter area is the sick area and the patient has ground glass opacity. In this case, the darker area has smaller vessels, so it is sick. And it means that the patient either has pulmonary artery hypertension or small airways disease. We do the expiratory CT scan, which is the second CT scan, and we see that the heterogeneity has increased. And that means that there is airway trapping consistent with small airways disease. But even if we weren't to do the expiratory CT scan, on the inspiratory CT scan, we can look to see if the bronchial walls are thickened and suggest that the finding is likely due to small airways disease. Or we can measure the size of the pulmonary artery, and if it's normal, then it's probably not pulmonary artery hypertension. Thank you. Next slide. What did you learn? Number 2, a 52-year-old woman has worsening indigestion over 6 to 9 months, persistent productive cough. The chest CT reveals diffuse basilar bronchiectasis. And what is the most likely diagnosis? We know when it's lower lung predominant, we think about chronic aspiration and MAI and dismodal cilia. And for a 52-year-old, the most likely diagnosis would be chronic aspiration, given her history of indigestion and productive cough. Next slide. How can imaging help to determine what treatment for bronchiectasis? How is it benefiting the clinician, our findings on chest CT? A 32-year-old man with asthma presents with dyspnea. A CT scan reveals central bronchiectasis with mucus plugging in a hand and glove pattern consistent with ABPA. What treatment would you recommend based on this diagnosis? Corticosteroids, chronic macrolides, CFTR modulator therapy, or suppressive antibiotics? The goals for treating bronchiectasis include relieving patient symptoms, minimizing progression, minimizing complications due to exacerbations, and improving the patient's quality of life. Next slide. There is important to have targeted treatments in patients with cystic fibrosis to treat the underlying cause of the disease, if that's possible, like recurrent aspiration, to treat comorbidities, and to target the pathophysiology. Next slide. When patients have increased wall thickness or mucus plugging, the best treatments include airway clearance therapies, such as chest physical therapy, or nebulized saline to help break up the viscous secretions. Next slide. And if the patient has micronodules like tree and bud, the best treatments will be chronic macrolides and antibiotics, suppressive antibiotics. Next slide. If the patient has central bronchiectasis, like ABPA, inhaled bronchodilators and corticosteroids would be the best treatment. So our imaging features help to guide treatment for the patient and are important for us to describe in our report. Next slide. So a 32-year-old man with a diagnosis of asthma presents with dyspnea. A CT scan reveals central bronchiectasis with mucus plugging and hand and glove pattern consistent with ABPA. What treatment would recommend based on this diagnosis and corticosteroids? Next slide. Should we follow up patients with imaging when they have bronchiectasis? How often should we follow up patients with bronchiectasis is the discussion for this section. Next slide. Which statement reflects recommendations or needs for CT imaging throughout the course of bronchiectasis? Guidelines only specify use in diagnosis. It should not be used except for people that are deteriorating. It is part of the risk severity scoring systems. Results are too variable for monitoring therapeutic response. Next slide. We can do subsequent imaging for a multitude of reasons, including surveillance to see how the patient is progressing, if they responded to an intervention by the clinician, if they're having worsening symptoms, and also for patient education. Next slide, please. In this case, we have a patient with MAI who has sputum cultures but limited symptoms. And the imaging 6 months later showed progression and cavitation. So this was a very important imaging finding for the clinician and for us to report that the patient is progressing. Next slide. Here's another patient with Mycobacterium. The images are obtained before initiation of therapy, and after therapy, we can see much improvement. So the follow-up imaging was helpful to know that we are on the right track in giving the medication that's most beneficial to the patient. Next slide, please. It's really important to recognize the severity of disease early because then we can talk about prognosis and whether we need to monitor the patient closer and change the therapy. We should do CT scan when patients are having deteriorating symptoms to see what's the reason for the deterioration. Is it the primary bronchiectasis or a secondary problem that has occurred? How do we quantify the amount of symptoms? The clinical quantification is considered mild if the patient has a lower number of symptoms or less intense symptoms, such as negative sputum cultures and sputum only once in a while, where we consider it moderate clinically if the symptoms are persistent and the patient needs antibiotics between exacerbations, and then severe if there's a large amount of purulent secretions. With frequent exacerbations and positive cultures, we consider that severe clinically. Next slide. Radiographically, we can also quantify the amount of bronchiectasis, and multiple systems have been developed, which is probably the challenge that there's not one uniform system to use. The bronchiectasis radiology index CT score, the BRIC score, is a simplified version of the BALA scoring. Mild is a BRICS 1, moderate is a BRICS 2 or 3, severe is a BRICS 4 or 5. So it's a score of 0 to 5, 0, no bronchiectasis, 5, a lot of bronchiectasis. The 0 to 3 component is the amount of dilatation of the bronchus, and then emphysema is considered as a part of it as well, giving the extra 2 points to get to a level of 5. Severity is important to for the patient to know so that you can counsel the patient about the importance of treatment. Next slide. Other radiology scoring system includes the REEF scoring system. And this one looks at the number of lobes involved, and it considers the lingula as a lobe. So it has 6 lobes, and you score 1 if the bronchiectasis is cylindrical, 2 if it's varicoid, and 3 if it's cystic. So you can get a score from 0 to 18. A score of 0 to 6 is considered mild radiographic bronchiectasis. Moderate is 7 to 12, and severe is 13 to 18. The REEF scoring system is relatively straightforward. Next one. Some other scoring systems that are combined with radiology include the Bronchiectasis Severity Index, and this is a score of less than 3. If less than 3 lobes are involved, you give a 0. If more than 3 lobes are involved, you give 1 point. The FACE scoring system gives, if 1 to 2 lobes are involved, you give 0. Greater than 2 lobes, you give 1 point. And then the E-FACE adds if the patient has exacerbation. So these are so many different scoring systems, but the goal is to assess in predicting how bad is this patient's bronchiectasis, how likely are they to have an exacerbation, are they going to be hospitalized, and do they have an increased risk of mortality? All the clinical and radiology scoring systems their aim is to decide how sick this patient is and what they have to do so that they stay well. Next slide, please. And knowing what the imaging shows can be helpful to the patient as well. This patient is saying, if somebody came along and said to me, if you don't do airway clearance every morning and night, you're going to get worse. Your bronchiectasis is going to get worse. It would probably have frightened me into doing better. So sometimes patients having that knowledge of how severe their bronchiectasis helps them to be more compliant with treatment. Next slide, please. Which statement reflects recommendations and or needs for CT imaging throughout the course of bronchiectasis? And the answer for this is it is included in risk severity scoring systems. Now we'll talk about a case to consider. A 56-year-old woman presents to the primary care with bronchitis, productive cough, difficulty taking deep breaths. She had flu 3 years ago, and she's having increasingly frequent and severe cases of bronchitis since that time. Her primary care physician put her on antibiotic therapy, and she's referred to radiology for a suspected pneumonia. Next slide, please. I'd like you to think about the answer to this question. Where in your practice have you seen delays in confirming bronchiectasis diagnosis? Have you noted that maybe people are unlikely or unwilling to call bronchiectasis early? Next slide, please. The initial imaging of our patient shows bronchiectasis. We see this patient is prone, they're laying on their stomach. We see significant bronchiectasis in the right middle lobe and the lingula with increased wall thickness. Because of its distribution and the patient's age, we think about MAI infection, and the severity index was considered 5 with moderate bronchiectasis. Next slide. Another question for you to reflect on. How often do you consider the potential impact of neutrophil inflammation on disease progression in patients with bronchiectasis and persistent infection? Do you think about that? Next slide, please. The patient improved after appropriate treatment and started airway clearance therapy. At 3 months, they were doing better. They had improved CT scan, reduced mucus plugging, and their symptoms were improved as well. So really pointing in a positive direction after 3 months. And the next slide, please. But after 1 year, the patient felt relatively well for 5 months, but then started feeling tired and coughing. She dropped off on her airway clearance therapy because she became too busy. The physician requested a follow-up CT scan, which on the first 3-month follow-up, there was improvement. And now on the later follow-up, there's progression. So there's an important for following up and being consistent with your patient's airway clearance therapy. Next slide, please. Another question for you to reflect on. How often do you share the CT scans with patients who have bronchiectasis? Do you review them with them so that they can see how much their bronchiectasis is? I have the opportunity sometimes as a radiologist to talk to our lung cancer screening patients. And when I show them their results or their images, they are so much more likely to stop smoking or to improve their diet and exercise. And so the image can go a long way for a patient's well-being. Next slide. The takeaway points for this lecture include the radiologist needs to be aware of the clinical characteristics of bronchiectasis as a chronic respiratory disease so that HRCT can be used for confirmation. The chest patterns of bronchiectasis can provide insight into the etiology and suggest appropriate treatments. Chest CT can be used to assess severity, but also to follow up to see if the treatment is working well and for educations of patients. Next slide. Future directions. What are we going to do in the future? What can we look forward to for bronchiectasis? I love the idea of this. New MRI that's very fast with respiratory gating holds the potential of being able to do imaging without radiation exposure. This is a healthy volunteer where we use this new technique. It took 2.5 minutes to perform. This patient was healthy, but there's a respiratory gating. So even if they were short of breath, we would be able to have less motion artifact and excellent quality images. Next slide. And then there's functional MRI image, which gives you like a VQ scan result where we can look at what areas are being ventilated, what areas are being perfused, and identify areas of mismatch. Next slide. MRI also offers us the opportunity to see if our treatments are working. The top row shows pre-treatment and the second row shows post-treatment, and we can see the improvement in lung function in certain areas after treatment and get validation that our treatments are working. So lots to look forward to in the future. Next slide. Thank you sincerely. It's a pleasure to be here today with you. I'm sorry for my intermittent coughing. It's very cold here in New York.
Thank you so much for sharing this lecture, Dr. Salvatore. Yes, we will open the floor now for some questions. If you've got any, please put them in the Q&A box so we can try to get through as many as we can before we close. We've got a couple in here already. So, can a patient have ABPA without bronchiectasis? I cannot say that word, apologies.
I think that they can, I have not seen a patient like that to be truthful. I think that there must be an early time where the bronchus is not so dilated, but they always have bronchiectasis in my experience. But the question is, oftentimes, can they have ABPA without having asthma and cystic fibrosis? And that too would be an exception to the rule and not the rule. Thank you for your question.
Can you please help to differentiate between cystic bronchiectasis and cystic lung disease?
Very interesting question. And cystic bronchiectasis tends to be more localized. When we think about cystic lung diseases, we think about, when we think about the diffuse ones, we can think about lymphangioliomyomatosis. It doesn't have as thick walls as the cystic bronchiectasis. Lymphocytic interstitial pneumonitis, which the cysts are not as thick walled. So I think that one of the main differences is the wall thickness of bronchiectasis compared to the cystic lung diseases, whether they be diffuse or focal. And great question. Thank you.
This one says, could you please review the slide on the distribution of bronchiectasis and treatment again?
So when there is wall thickness and mucus plugging, then anything to bring that mucus up would be helpful, like Nebulized saline makes the secretions less thick. I was a physical therapist before I became a doctor, and I used to go into patients' room and do chest percussion like this. And that would help bring up secretions. The patient in the picture had a vest on, which helped to bring up the secretions as well. In contrast, the next slide. When patients have tree and bud, like nodules, we think about antibiotics and macrolides. And the next slide, for ABPA, bronchodilators and corticosteroids are recommended. I think more from a radiologic perspective, describing the pattern is important so the clinician can make the best decision as to the treatment. Thank you.
That feels like a good segue to this question. How do you recommend reporting the severity of bronchiectasis in our CT reports?
So I think, although we have all these different grading systems, what most people use are Lynn Reed's original 1950s grading of whether it's cylindrical, meaning it's smoothly dilated, versus varicoid, where it's undulating, and then cystic when it looks like a cluster of grapes. That might be a little bit unsatisfying because it doesn't show extent. It only shows severity of one bronchus being dilated. Probably the best scoring systems would be like the Reef system that says how many lobes are involved and how dilated each bronchus is. And that was on a score of 0 to 18. And I think that's a very good way of looking at bronchiectasis.
Got two more questions. When is prone CT recommended to use? When is it recommended to use prone CT?
Thank you for this question. I rarely have used prone CT scan. I think it's more useful in pulmonary fibrosis when it's very early pulmonary fibrosis and you wonder if it's dependent atelectasis or true fibrosis. When patients lay on the CT scan table getting intravenous contrast, it could be that they're there for maybe 15 minutes. And so I only use prone positioning when I think it could be early interstitial lung disease versus atelectasis. So I'm looking for dilated bronchi. If the bronchi are dilated in the prone position, then I know that it is, or even in the supine position, I know that it is fibrosis and not atelectasis.
Fantastic. All right, one more. We might have to hunt through the slides on this one. Can you review the section on arterial bronchial diameter changes based on GGO versus small vessel disease?
That's a great and a complicated slide. So we can try to, where was that slide? It was after the end of the different patterns of bronchiectasis. I think we should go backwards. I think it'll be there. There it is. Perfect. So one forward from here. Do you see, that's the one. Do you see my mouse when I move?
No,
No.
we don't see yours.
Okay, so when we look at the first CT scan image, we see behind the right major fissure, there's an area of lucency. Now you can say on the CT scan that this is mosaic attenuation because there's an area of lucency and there's an area of normal lung, and mosaic just means heterogeneous. Now, when you look at the area of lucency, are the blood vessels small in that area? More small than the area that are less lucent? And I think that they are. So you have small blood vessels in that area. They're either small because of pruning from pulmonary artery hypertension, or they're small because of the relative hypoxia of that area due to air trapping. So when you see that the blood vessels are smaller in the dark area, your patient either has pulmonary artery hypertension or small airways disease. Now you could just stick with this X-ray and at this CT scan, and how can you exclude pulmonary artery hypertension? Look at the size of the pulmonary artery. If it's smaller than the aorta, then they don't have pulmonary artery hypertension. And this lucency must be because of small airways disease. If the pulmonary artery is big, it may be that they have pulmonary artery hypertension and small airways disease. If the bronchial walls are thickened, it's probably that they have small airways disease. But many people will do an expiratory CT scan, which is also helpful if it's good quality. And if the heterogeneity becomes more significant, then it's small airways disease. And if it doesn't, then it's pulmonary artery hypertension. So those are the steps. First, you look at the inspiratory and the size of the vessels. And if they're small, then the black area is sick. If they are equal, then the white area is sick and the patient has ground glass opacity from infection, hemorrhage, edema, all the different causes. Thank you for your question. Thank you for the opportunity to say that again.
Well, thank you so much for answering those questions. We've gotten through them all. And thank you so much for being here and giving this awesome lecture, Dr. Salvatore.
Thank you. My pleasure. Have a great day today, everybody. Thank you for participating.
Yes, everyone, thank you for those great questions and for participating in our noon conference. You can access the recording of today's conference and all our previous noon conferences by creating a free account. We will also email out a link to the replay later today. Be sure to join us next week on Thursday, January 16th at 12 p.m. Eastern, where Dr. Douglas Katz will deliver a lecture entitled Imaging of Acute Abdominal and Pelvic Conditions in Pregnancy. You can register for that at mrionline.com and follow us on social media for updates on future noon conferences. Thanks again and have a great day.